this weaning criteria basically every morning. So every 24 hours. It's typically done in the morning on the first rounds. Some places do it at 4 a.m. I do not agree with trying to wean a patient at 4 a.m. It's the middle of the night. Let them wake up, let's get the sun out, let's get things looking normal. And the whole idea to doing it first thing in the morning is we can see if our patients are ready to wean, try to wean them, and be able to report to the doctor when he comes for rounds. Because you know everybody's doing rounds between like 9 and 11. So by the time he gets there, we can let them know they're ready to be extubated, or they didn't pass, or we didn't even try, and here's why. Okay? So they pass everything. Now we're going to a spontaneous breathing trial, SBT. So this could be an old-fashioned T-piece, corrugated tubing to the large volume nebulizer, right? You guys good with that? So an old-fashioned T-piece. It could be pressure support, CPAP, or just plain old CPAP by itself. So this would be pressure support less than 10, CPAP less than 10, or around there. Some people like 10. I personally would want them to be more on 5, but there are some other modes they're using, but there's some other weaning modes on the vents, but nobody's really using them, so I'm not going to get into those. The standard weaning is to either go on an old-fashioned T-piece. The most standard weaning is pressure support and CPAP. So take off the rate, we're gonna just go in straight pressure support mode with some CPAP on there. And now we can start looking at how our patient is doing. So, and this is gonna be a 5-minute quick SBT, because right now, we just wanna see if our patient's gonna tolerate it at all. Some patients, you guys, as soon as you put them on this, they automatically, some of you guys seen that in your clinic settings, of those of you who've been able to get into the ICU. You put them over to an SBT and immediately their rate goes up, their sats go down, the patient's just not happy. Tidal volumes are really low. And I'm not talking about a patient who's anxious, I'm just talking about a patient who's not tolerating it. So what are we gonna look at now? So we need to monitor our vitals, of course. So respiratory rate, heart rate, SpO2, blood pressure. I think we all know by now changes of 20 or more are too much. That's pretty standard. Vital capacity, MIP, NIF, tidal volume. If those, go back and look at the lecture. I'm not going to go over all those critical values. You guys know what they are because we've talked about them before. So we want our vital capacities to be good. In the real world, you're not seeing a lot of vital capacities. We're going to be mostly doing NIFs and tidal volumes. The test will always have vital capacities on it though. And then the RSBI. That's a big one now. It's the rapid shallow breathing index. And it is the respiratory rate divided by the tidal volume in liters. And it needs to be, a good value is less than 105. RSBI is used all the time now in weaning, both clinically and on your test. So if all of your data is marginal, but your RSBI is good, you're gonna go ahead and keep going. So everything's good, you know, maybe the NIF is -25, the tidal volume's like 250, 300, but if your RSBI is good, your patient's maintaining well, so you're gonna go ahead and keep going. So we're looking at this a lot. So if they tolerate So you're staying in the room while this is happening. You're monitoring everything. You're documenting it all. It all goes fine. Then we continue the SBT. So everything's good. Bad. Go back to previous settings. And evaluate your patient. Like, is there anything you missed? Can you see any reason why they might not have passed? Try again tomorrow. So we want to be able to continue the SBT for a minimum of 30 minutes. So if your patient can do a minimum of 30 minutes, then we're going to extubate. If they can't tolerate for 30 minutes, we're going to go there. So that's our little. And we'll extubate after we get the doctor's order. Extubating is never part of the protocol. You will never take the tube out until the doctor gives the go-ahead. Not the nurse, the doctor. Nothing against nurses, but there are some nurses out there who like to tell you what to do. And they'll tell you, everything's good, let's extubate. If you talk to the doctor, where's the order? You don't have it, you don't take the tube out. You take the tube out and something goes wrong, that doctor will have your head because he never wrote the order. So you need to have the order. Sorry guys, you can't see. Try to. There's one other important thing you have to look at before you officially extubate your patient, and kind of where it falls in this process is kind of like RT dependent, but it's called the cuff leak test. At some point, you don't need an order for the cuff leak test. You may not do it every single time. All we're doing with the cuff leak test is taking air out of the cuff and making sure that we get a leak and we can hear air movement going around the endotracheal tube so that you know you don't have swollen tissue and be prone to laryngospasms. So you literally take the air out of the cuff. You should be able to hear that gurgling sound. If you haven't heard it yet, you'll know what I mean. When that air is out of the cuff, it's a very, very obvious sound. You will also see your tidal volume drop because you've just created a leak. And so air should be moving out of the mouth. Does that make sense to everybody? Mm-hmm. So that's all a cuff leak test is. It should just be done before you actually extubate, especially if your patient had upper airway surgery, anaphylactic shock, maybe they have had a swollen tongue, previous attempts to extubate where they went into stridor. There'll be some patients where you tried to extubate them in the past and they went right into stridor and didn't tolerate it. So now you're trying to do it again. Well, you already know. People that go into stridor tend to be prone to go into stridor. So if they did it once, there's a good chance they'll do it again. So sometimes, you guys know this from extubation, sometimes there's nothing, you could have never known. There's nothing, everything looks perfect. You take the tube out and there they go, down the can. Marked stridor, what are we gonna do?
Reintubate.
Reintubate. Mild to moderate.
Epinephrine.
C-Mist. Cool Mist. Good job.